Dr. A. Rajmani, Dr. Rupendra, and all the people who are watching this. I'm glad that on the World Spine Day, that Trichy Orthopaedic Club has taken this initiative to organize this webinar on the spine. And I wish this program all the very best. And the webinar is inaugurated for further scientific deliberation. Thank you very much for having me here today. Thank you. Over to you, Jaikesh.
Thank you, sir. Now, Dr. Panikiran.
Thank you, sir. I thank you for this opportunity to speak on World Spine Day. So this is a very important topic because it's one of the common traps for those who are venturing into spine surgeries. It's very common that we see there is a patient with a back pain and an MRI which shows there is a black disc, and many times it is considered as the cause for back pain, and treatments are done, sometimes even surgical, and that leads to bad results. So it's very important to understand, does it represent? Let me just define what a black disc means. It's basically a degeneration of the disc, which is a natural process, and the MRI grading, the hypo-intensity that develops in the disc due to the degeneration is what results in this appearance. But it's important to know what is the correlation between the MRI picture and the clinical symptoms, whether they are related or not, and how much, and whether the priority is treating the patient or treating the MRI. So the questions that arise are, what is the prevalence of such MRI changes where there are degenerative changes, there is hypointensity, and there are black discs at one or multiple levels? What is the prevalence without symptoms, and what percentage of these black discs that we, so-called black discs that we see, are responsible for symptoms? And one has to be questioning themselves whether they are sure that this disc is the reason for the symptoms that the patient has. And there is a huge number of patients with non-specific back pain. So it is very common that you might end up seeing a patient with black disc with non-specific back pain. So just as we all know, the structure of the disc, the nucleus pulposus with highly negatively charged hyaluronate molecules which retain the water, and the annulus fibrosus. The integrity of the annular fibers is important to maintain the function of the disc, maintaining the root stresses. And when these wear and tear changes happen and the integrity of the annulus fibrosus is altered, and the ability to retain water molecules in the nucleus is altered, that's when these altered biomechanics start off the degenerative changes. The central part of the disc, the nucleus, where there is low levels of oxygen and glucose and high levels of lactic acid, that's where the loss of cellular activity happens and starts off the cascade. And as one ages, the atherosclerosis and end plate calcification also affects the nutrition of the disc. So this is how the degeneration of the disc happens as the person ages. You can see that the discrimination, the differentiation between the nucleus pulposus and the annulus fibrosus is less and less clear, and eventually there is a loss of disc height and collapse of disc at the end. So that is what we see on the MRI too, the representation of these changes. And this is the performance grading on the MRI T2 sagittal images, where we see that there are 5 grades. There is hyperintense central nucleus with a clear annulus fibrosus. In grade 1, the intensity is almost equal to the CSF intensity. As the changes progress, there are some inhomogeneity inside the disc. You can see the gray horizontal lines, and we hypointensity increases further with loss of disc height and collapse. So this is how the performance grading was described. So one needs to look at the homogeneity of the hyperintense central disc nucleus pulposus and the differentiation between the nucleus and the annulus and the disc height. And there was a further modification later on which added these the disc height grading to address the problem of older age people where the changes were almost all the changes were being graded as grade 4 or 5 in the initial grading. So if you see this almost from grade 3 onwards, it is all of them have a black disc, so-called black disc on the MRI. So when you see a patient, such patient with MRI changes, one needs to think whether they're too close to the tree to miss the forest. So are the MRI changes responsible for the symptoms is what one should think, and look at the facet joints, look at the SI joints, or clinically examine and see if there are is there any instability on the imaging, and what is the lifestyle of the patient, and what are the functional disabilities that he has. So all these things need to be seen. So one needs to remember that it's highly common to have back pain, and almost 85% of the population there is at one point in their life they have significant back pain. So there is a high prevalence of non-specific back pain, which means there is no morphological correlate to address as a reason, as a responsible reason for back pain. So, and at the same time, one must also remember that there is a high incidence of these MRI changes in asymptomatic patients. So in this systematic review, if you see in the decades of 20s, 30s, 40s, even in that age, there are asymptomatic disc changes in almost 30-40%. And as one ages, it is increasing up to 80-90%. So it's fairly common to have these changes without symptoms. So when you combine these two facts, that there is a lot of there's a huge group of changes on the MRI, and there is another huge group of patients who have non-specific back pain, which does not have a morphological correlate. So there is it's kind of a trap where you can easily end up treating a non-specific patient with asymptomatic black disc. So that's what we should avoid. So that means clinical examination, thorough history, and comprehensive examination is very, very important. And investigations are used as a supporting this thing. And one should remember that it's multifactorial chronic low back pain, and assess the patient in detail, assess the functional disability, and rule out other systems, other possible causes of back pain, like pain coming from the hip joints or SI joints or pelvic organ. So all this is important in clinical evaluation. So the main aim of clinical evaluation should be to differentiate whether there are specific disorders which can correlate with the imaging that is there, or there is no correlation clinically between the imaging and the patient's signs and symptoms. And we must look at the possible sources of pain, whether it's from the disc, facet joints, the ligaments, paraspinal muscles. So this clinical evaluation is very, very important. And to just define discogenic back pain is something that originates from the disc with the development of fissures in the annulus fibrosus, which there is neovascularization and that makes it sensitive to pain. And this is a little different from the back pain that is due to a disc prolapse. So there may not be much of a disc prolapse, but the disc can still cause pain in such cases. And at the same time, one must also remember that when those with patients with chronic back pain, they have pain-induced distress and disability, which may vary to various degrees, and some of them develop this illness behavior, and when it's very severe, they are in a sick role. So one needs to identify such patients who have developed these behavioral alterations due to chronic pain, and it's important to deal with those symptoms and illness behavior, to identify and treat them appropriately. Otherwise, it's not going to respond to the routine treatment. And additional imaging is very important to see if to look at if there is any instability or sometimes a spondylolisthesis, which may not be seen so well on the MRI. So dynamic X-rays are helpful. So usually, if you consider treatment options, one can see that rarely for axial back pain alone, there is anything surgical that is advised, unless there is some radicular symptoms or neurological deficits, claudication. It's very rare that one needs to consider surgery. So most of these patients are conservatively managed, and it's very, very important to educate the patient about what is happening. There's a lot of fear and distress in their minds when there is pain and there are MRI changes. It's very common that there is a lot of fear. So that needs to be allayed with proper patient education, reassuring them about the problem. And usual treatment is, we all know that initial short period of rest with NSAIDs and skeletal muscle relaxants is good. The evidence for the use of opioids, antidepressants, duloxetine is one of them, which has some evidence, but otherwise it is not very strong evidence that these agents, the anti-epileptic agents or steroids, are really beneficial. Steroids are more beneficial in the presence of radicular symptoms, but not so much in the presence of axial back pain alone. So it is what works mostly is physiotherapy modalities, posture precautions. Most of these, most common reason for back pain nowadays is bad posture related overstrain. So one needs to educate them about posture corrections and about office ergonomics. Lifestyle modifications is important. That otherwise, once they don't change their lifestyle, the pain is going to keep coming back. And proper comprehensive exercise program. So this is what really works for such patients, and there is strong evidence that this multidisciplinary psychosocial rehabilitation is what really works in this kind of chronic back pain. So again, the education of the patient, back schools have been shown to really work with structured exercise programs. So there needs to be a multidisciplinary approach with the help of physiotherapists and psychological counselors and exercise programs. Some physiotherapy modalities that really help in such patients. But when this is not responding to these, there are other options like injection procedures. One needs to clinically decide what exactly is the source of pain, and if it is a myofascial syndrome, trigger point injections are quite helpful in reducing the pain and helping them to get on the exercise program. Facet joint blocks is something that is done very commonly, and even if there is a clinical suspicion, SI joint injections. Epidural injections are more useful in radicular, but there is evidence that there is significant evidence that it helps in axial back pain as well. It is more beneficial to give in the interlaminar or transcolumnar than caudal epidural, which may not reach the higher disc levels. There is discography is one of the techniques where one tries to ascertain whether the black disc is the cause for pain and to see the confidence of pain. But there are some concerns with discography that it may accelerate disc degeneration, so that needs to be done very carefully or could be avoided if possible. Now there is recently this regenerative cell-based therapies. There is very low quality evidence, and it's still something that we should not start using without proper consideration. The other injection procedures like intradiscal electropharyngeal ablations or radio frequency ablations are also considered available, but again, the evidence is poor that these things really make a difference. So this is just to the award-winning paper that the discography can accelerate regeneration in the lumbar discs. Surgical options are, as I said, it's rarely required for an axial back pain alone in a very selected group of patients. So there are endoscopic surgeons who recommend annular debridement of the annular lesions, the granulation tissue, and ablating the neovascularized tissue in the annulus, which can reduce the back pain. But most commonly, the fusion surgery is what is done. But there is a lot of evidence now saying that the fusion is not much better than the physiotherapy and exercises and epidural injections. There is no significant real long-term benefit with fusion. The other options also, dynamic stabilization and disc replacement. Again, the evidence does not support any major advantage over non-surgical options. So there are a few studies which say that fusion is the people with fusion had a better parameters than conservative management. But then the quality of studies is not great. The number of cases was very low, and there are few studies which clearly establish that the evidence is poor, and the epidural injections and conservative management have better evidence and equal results when compared to surgical treatments. So just to summarize, one needs to be very careful when they see the back disc on MRI with the patient with back pain. What is the real cause of back pain that needs to be evaluated? Look for other sources of pain. It is more likely that there is some other reason for pain than the back disc itself, because there is a huge prevalence of asymptomatic changes on the MRI. And look at the presence of any postural strains, myofascial syndromes, which are very common, depend on the patient's lifestyle and psychosocial behavior, needs to be evaluated. And the multidisciplinary biopsychosocial rehabilitation is what really works, and injection procedures are very useful. Surgery is rarely required with a low level of evidence that they are better than other options. So, thank you.
Thank you, Dr. Fanikiran. Can I ask you one or two things?
Yeah.
Black disc as such indicates degeneration of the disc. Is there any correlation with the facetal joint arthrosis associated with the black disc in the literature?
Yes. There is association. There have been studies which have graded the degeneration of the disc and compared it with the facet degeneration, and those with reduced disc height, they tend to have grades of facet joint degeneration as well, because the disc and the facet joint in that segment, they function as a unit. So that's why it's very important, and these facet joints are more common sources of pain than the disc itself, and that's why many of these patients, they benefit with facet joint blocks. So one has to look for degenerative changes in the facet joints as well.
Sure.
Sir, in case of black disc, which you prefer, like epidural injection or selective nerve root block?
That depends on the clinical picture of the patient. If there is no other clinical finding that other sources of pain are not there, then the most commonly what I do is a facet joint block, and many of them they respond with it, and less commonly there is a need for doing an epidural injection for axial back pain alone. Only if there is a radicular pain, that there is real benefit in using an epidural steroid. So most commonly I use, if it's only axial back pain, facet joint blocks are what help, along with physiotherapy and rehabilitation exercises. And most of them respond well. Is it clear, or should I repeat?
It is clear.
Thank you. So, Jaikish, shall I go ahead with the case presentations?
Okay.
The host has to unmute or screen sharing has to be allowed.
Ramesh?
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 Yeah, yes, sir. Yes, sir. Yes, 1 minute.
Please allow the screen sharing for me.
Okay,
Subramanian.
Yes, sir. No, there is 1 minute, sir.
Is Ajay there? Hello?
Yes.
Ajay, how do you deal with black discs? One or more than 1, 2, 3 black discs?
Most of the time conservative. Most of the time we treat them conservatively. Very rarely, sometimes we investigate with the CT. If they show some end plate changes or anything, significant features of it, we may have to think of doing other procedures like biopsy or things like that. But most of them will be conservative exercises. But most of them, probably what happens is that they may not come back to you for follow-up after some time. Because when you advise conservative for first visit, second visit, either they become all right, or most of them may feel that it's not going to change, or they accept it or move to a new doctor. We never operate for a back pain per se, and especially for a black disc.
Yes, the literature is against it, against doing surgery for per se axial back pain alone, isn't it?
But I think the other problem is that we as surgeons tend to think more of a surgical cause. The patient is not a surgical cause. Our focus on management changes. And if you spend time and advise them good conservative care, I mean, a significant percentage of them do become better.
Sure. We need to establish a support system to deal with these patients, because in a busy clinic, it is difficult to spend much time on the emphasis on exercises and lifestyle modifications and so on. So in the UK, they used to have spine assessment clinic, where it was run by a nurse consultant, a senior most nurse level person who runs the clinic in a very efficient way with a lot of they used to have connections with the local gym and so on to send these kind of patients to for regular treatment and back exercises and lifestyle modification kind of thing. Because in a busy clinic, we don't have much time to spend on these patients. Yeah, you know what I mean.
Yeah, I understand.
So still, Jaikish, my screen I'm unable to share. Ramesh, are you there? Hello, Ramesh.
And we'll go to next talk.
Okay.
Is it okay, Balasan sir?
Yeah, fine. No problem. Please go ahead.
Can I do mine? If Dr. Rajamani has not come.
Yeah, why not? Let Ajay do his.
Hi, Upendra.
Okay, sir.
Okay, sure. 1 second, please.
Mr. Jagan, you're on the line.
Yeah, I'm on there. I'm there.
Right.
Mr.
Can hear
Jagan, can you make it Dr. Balasubramaniam as a co-host?
Yeah, just a moment.
You can see my screen. Shall
Yeah, we are seeing, sir.
Yes, sir. We are seeing.
Yeah.
Good evening, everybody. It's a great pleasure to be here with you today on the World Spine Day. My special thanks to Jaikesh for having me here, and greetings to all my colleagues and co-faculty and friends and the listeners. My talk would be on lytic spondylolisthesis, the importance of open TLIF versus an MIS.
No, I'm just searching him. Hold a second. Let me just. Dr. K. Balasubramanian.
Can
Yes,
you just, yeah. Lumbar interbody fusion is an established treatment in the management of various pathologies like degenerative, trauma, infection, and neoplasm. The technique could be either from the back. The commonly used is posterior lumbar interbody fusion or transforaminal lumbar interbody fusion. Or it can be from the side, that is the X-cliff or the lateral lumbar interbody fusion. Or it can be from the front. Am I audible?
What, Jagan? Why if this is a highly disturbance of this? We should not give
Ramesh, mute yourself.
Ramesh, mute yourself.
Ramesh, mute yourself, please.
Yeah. The thing is, and also from the front, that is called the anterior lumbar interbody fusion. The concept of transforaminal lumbar interbody fusion was first put forward by Jugan Harms in 1982. It could be an open procedure or it could be an MIS mini open technique. As you can see in this picture, the basic advantage when you do a transforaminal lumbar interbody fusion, you excise the inferior facet. You excise the superior facet on one side and then enter between the exiting root above and the traversing root below. You excise the disc and then you are into the interbody area. Therefore, the advantage of this procedure over the PLIF is the fact that you can achieve an interbody fusion without disturbing the nerve root or the thecal sac. The chances of postoperative radiculopathy could be lesser. It depends upon the size of the collapse of the disc space. The chance of injury to the nerve root also could be lesser. And that's one of the major advantage. By approaching from one side, Harms et al. Showed that you can clear up to 80% of the disc, especially the inner aspect of the inner part of the annulus and also the nucleus pulposus. And literature has shown that the posterolateral fusion is very inferior when compared to TLIF with regards to the fusion rate. And TLIF, most importantly, as you can see, it increases the height of the intervertebral foramen. It gives an anterior column support, and it restores the lumbar lordosis. I will just show a small video of a open interbody fusion procedure. But this video is recorded for a degenerative listhesis, not for a lytic listhesis. And as you can see, the amount of exposure becomes significantly more when you do an open procedure. You have to detach the muscles from the midline, from the fascia, and the fascia from the midline. This is basically essential for you to pass the pedicle screws, because the majority of your exposure is not to do the interbody work, it's basically to pass the pedicle screws per se, and it depends upon the quality of the musculature for the patient for whom you are going to do the procedure. Once you have done that aspect, you have to, we prefer to do a total laminectomy and bilateral decompression, especially when you are doing a fusion, unless the patient has got a recurrent disc prolapse for which we are doing a fusion, or a situation wherein the pathology is only on one side. But whenever the patient has got a stenosis, we tend to decompress, we remove the midline and tend to decompress on bilaterally when we do an open procedure. Even though I do MIS procedures, it may be limited to only 5% of my lumbar fusions, probably lesser, because it takes time and you have been doing open for a long time. Therefore, you find it much more convenient to do it. I prefer to do a TLIF basically for a recurrent disc or a lytic listhesis, because you need not worry too much about the decompression element. The side you approach, and by jacking up the disc space, you can achieve the reduction and also achieve the stability and the decompression. Once you have decompressed, the basic entry into the interbody space is between the nerve roots of L4 and L5 in a situation of L4-5. The thecal sac can be gently retracted or protected by a nerve root retractor. You get into the disc space, use various size of rasp or sizes to loosen the disc. That's also very, very essential. When you're doing interbody procedure from behind, you basically loosen the disc by using a different sizes as you go incrementally from 6 to 11 to 12 millimeters, depending upon the size of the disc. It basically loosens the disc, which you can further empty by using a disc forceps. It's also important to remove the bony end plate, not to damage the cartilaginous end plate. So that your preparation is very, very important. We should remember our primary aim is to fuse. The bone that is removed is made into pieces using a funnel. You pack it into the disc space, followed by the introduction of the cage. As you can see, when you do an open procedure, you get a significant amount of graft, which will ensure that the fusion procedure, what we are doing in the end, will be quite good. But it's also important that you do an adequate amount of preparation of the disc space, remove the disc adequately, pack the bone significantly anterior. And whenever you are introducing the cage in, it should be protected. The nerve root should be protected. And you can see the size of the cage. Actually, the size of this cage could have been slightly bigger. Position should be across the midline ideally. And then after compression, you can see there is a good amount of lordosis and a proper adequately positioned instrumentation. There are various types of listhesis. Whereas if you look at the degenerative or a dysplastic, which is a high-grade listhesis, you need to have a center decompression. In a dysplastic listhesis, when the grade becomes more than grade 2, you need much more technical skill to do an MIS procedure to achieve a good amount of reduction and to get into the space. Whereas a lytic, the basic problem is instability, and probably an ideal case to do an MIS. Whereas in a degenerative, it's still comfortable to do an MIS, but it needs for you to decompress the whole of the canal, wherein you need to approach onto the other side to achieve the procedure. As you can see in this picture, what is important is when you look at the MRI and the X-ray, you see in the MRI, it's almost reduced. That means to say this is an easily reducible one. And as you can see in the postoperative picture, it is usually reduced. You don't have to put in a great effort to achieve the reduction. Therefore, your primary aim should not be to achieve a complete reduction, whichever that comes comfortably. Even if you achieve a partial reduction, even if it is grade 2 to grade 1 or grade 1 to grade 0, it's adequate. You don't have to be struggled too much. What is important is to give stability, number one, reduce the kyphosis that is there around. Which interbody device is better? There are different types of cages. It depends. You can have expandable to non-expandable to bullet to banana cage to mesh cage. Of all these cages, for the ease and practicality of use, the bullet cage is comparatively very simple to use. It comes in different length so that it has to extend from one end from posterior to anterior. And we prefer to use a bullet cage because of the ease of application of it. There are various interbody cage materials, the PEEK, titanium, mesh, but it doesn't make much difference. But however, remember, if you are going to do an interbody fusion for a lytic listhesis, it's always better to use a structural device rather than put morselized bone graft into it. It's okay if you're doing interbody fusion for a degenerative listhesis, morselized grafts could be adequate. But however, what we have noticed is, especially in lytic listhesis, more so at L5S1, a good structural support along with the chips of bone grafts in between is very essential for you to get a structural support and a good fusion and to prevent implant failures. But open TLIFs has its got own share of complication. The most important thing is infection. Okay, the screw malposition, durotomy, they are all complications whether you do a open or a percutaneous method or a MIS technique. MIS was introduced in 2000 and now it has become a norm and probably is definitely superior when compared to opens procedures. MIS by itself is a procedure that by virtue of extent, it causes less tissue damage, decreases the morbidity and early functional recovery. As against to open technique as shown in the figure below, it's a target surgery with a minimum of iatrogenic trauma. The entry is adequate, but it's very small. The route is fast and directly up to the target area. The collateral damage, that is the damage to the musculature around, is very negligible. But having said that, with all these things, the target exposure is adequate and it's efficient. Why did MIS become so popular in the last few decades? I mean, it's basically because of advances in science. I mean, if you see the access has become better, you get a better retractors, you got better scopes, you can use microscope or endoscope. You got navigation systems so that a radiation hazard is not there, and the instrumentation and tools have made it possible for MIS procedures to gain popularity. There's a minimum soft tissue disruption, and you can do a bilateral decompression even though it takes experience and expertise. The basic advantage of MIS techniques over an open technique is the fact that the musculature damage is very less. We have to remember that the minimal access surgery in spine is different from an arthroscopy or a laparoscope. When you take an arthroscope, I mean a knee joint scope, is basically you got a cavity which can be inflated with saline so that you can see the whole area much better. Whereas in spine, the MIS means is basically an access through an intramuscular plane or an intramuscular plane. Basically what you do is that when the muscle is erased from the bony attachment, it's the fascia is separated from the bony attachment as you do in an open procedure. It doesn't attach to the bone in the same manner. It attaches with the scar tissue. The amount of muscular damage is significantly more. And we know that multifidus muscle and the thoracolumbar fascia is very, very important musculature for the function of the back. You can see this is the difference between an incision between an open and a minimally accessed procedure. You access through a tube, which is usually table mounted so that it doesn't move much. You've got different types of tube that is available. The basic disadvantage is because when you are putting the screws, you need to use image intensifier to put the screws. You can use navigation to reduce the amount of radiation, but it increases the cost of the overall procedure. Then you have a tubular access, which is directly placed over the facet joint so that you will be able to approach into the interlaminar space. There are various types of retractors. Probably the non-expandable are the one which causes the less amount of creep of musculature inside. Whereas the expandable one, as you expand, the muscle tends to creep in. You may have to keep adjusting it or exercising more amount of muscle to it. Just to show a video. It's not my video per se, it's basically Arvind's video, just edited for a short duration. TLIF has got two components, the interbody part. Basically, when you have a tubular retractor, depending on what you are using it for. If you are going to do a recurrent disc, you can place it just over the facet. As you can see, there is always some degree of musculature you need to excise before you get onto the bone. And usually, since it's placed over the facet joint, you can use an osteotome or a burr. The advantage of using the osteotome is that you get bone which can be used over it. Can be used for the interbody procedures. You can do over-the-top decompression. And this is very, very essential when you are doing a degenerative listhesis. Whereas in the lytic, you don't need to decompress on the other side. You just need to decompress on your side and then do an interbody fusion procedures. As you can see, since you have placed it directly over the facet joint, it's quite easy for you to access the disc space and to do the interbody work. Further procedure is similar to like how you do in the open thing. But you have to remember, when you are doing through a smaller tubular access, your interbody preparation has to be much more meticulous, because you may not be able to achieve the similar degree of interbody preparation as you can do it by open procedure, unless you are focused, unless you are experienced to do that. Most of the MIS in the initial years had a lot of bad reputation only because people trying to do it by tube but not able to achieve the desired results. The screws are then passed over a guide wire, and as you can see, this is the final results. Therefore, there are 5 tiers of invasiveness. I mean, you have the open at one end and endoscopic at the other end. Therefore, there is no doubt in anybody's mind that when you do into a minimal access, the amount of muscular damage becomes significantly less. But however, to move to do MIS for everything could be a technical challenge, especially in conjunctive root with high-grade listhesis. It could be a technical, that is not that it's impossible. There are people who do it, but it's a technical challenge. The complications could be higher. Actually, in obesity, if you have a good tubular retractor, it actually makes your life easy to do MIS still if rather than doing an open procedure. I'm sure, I mean, if you ask Mukesh to say to do a discectomy in an obese individual is much more difficult as against to doing it through an endoscope. But when you have a high-grade listhesis like this, it's still a challenge to do by MIS techniques, especially in a high-grade dysplastic listhesis in a young child, which is not reducible per se. Whereas open procedure still is the one which can give you much more better results. It has got its own problem like learning curve, longer operating time, and radiation exposure, which has now been mitigated by the advancement of transforaminal lumbar interbody fusion by using navigation. But we should remember the navigation does not mean that you have reduced the incidence of screw malposition, but it definitely reduces the amount of radiation the surgeon gets, but not the radiation the patient gets it. What about the long-term outcome? Is there a difference between MIS and open? Yes, in the sense there is no major difference with regards to outcome in the long term, but in the short term, there is an improved functional mobility, decreased use of post-operative medications. And because the patients can be discharged much earlier, maybe the cost-wise is not significantly higher. Complication-wise, in 2015, they are almost similar, whereas the complication of MIF TLIF with regards to revision was higher. But if you see now 5 years down the line, the people have become much more experienced in doing MIS. Younger surgeons have been trained to do MIS from day one of their training. And therefore, the incidence of complication with MIS surgeries are gradually coming down. There is certain disadvantages. In MIS, to get a lumbar lordosis, you need to access from the other side also, because you are removing only one facet. It's very difficult to get a lumbar lordosis. When you need a lumbar lordosis, it's important from the other side where you are putting the screw, you may have to burr off the facet joint so that it allows you to put a screw and compress. Because the evidence as such today is not in favor of restoration of lumbar lordosis after MIS TLIF, which you can easily do by an open TLIF. When you do an open TLIF, your restoration of lumbar lordosis is significantly higher. It may not matter in majority of the single level fusions we do, but in certain patients, when you think that you need to restore the lumbar lordosis, probably you can use an open procedure or excise the facet on both sides to achieve the same. Comparing to the adjacent segment degeneration, is again a skill for you to avoid damaging the upper facet when you are putting the percutaneous screws. The incidence is as similar to the open procedure as things stands today. With using navigation, probably the incidence rates comes down significantly. To conclude, open TLIF still remains the gold standard, but however, MIS TLIF is not far behind. Maybe in another 5 years, majority of the procedure, 5 to 10 years, maybe majority of the procedures will tend to become an MIS approach, that is using a tube access
to the particular spot where you can achieve the same results with minimal morbidity and collateral damage. Thank you very much. Hello.
Thank you, sir. It's an excellent talk.
Thank you. Mukesh, do you have any questions?
Sir, yes, sir. Sir, good evening, sir.
Good evening, Mukesh.
Wonderful talk, sir. One more doubt, sir. You were telling that you will be doing a midline.
Sorry, there was a disturbance. You will be doing a midline decompression.
Midline decompression for a regular T-lift.
Yes.
Just
that we have been trained and you are comfortable, you get a lot of bone for it.
Yeah.
But it's not absolutely necessary unless there is a severe stenosis. It's not necessary to remove the midline.
Okay.
It's just that it makes your procedure much faster. The light ecchystosis saving the midline doesn't make much difference because already the posterior rattler is free. Excising it gives you some comfortable amount of bone for you to do interbody fusion.
Right. Okay. Because there are people who suggest that we shouldn't touch the midline and we should preserve it. And what does it say on it?
Yeah, definitely yes. I mean, I would agree that whenever it's possible, it's always better to save the midline. It definitely gives some degree of stability, and the posterior midline structures are helpful to prevent the adjacent segment degeneration. In a light ecchystosis, it wouldn't make any difference because they are already dysfunctional. We have to understand the posterior lateral is free. The posterior interspinous and the supraspinous ligaments are relatively lax. It doesn't show much stability. Maybe in a degenerative listhesis, biomechanical studies have shown it, but I'm not sure whether clinical studies have shown the advantage of it in the long term.
Right. Yes.
But definitely the post-operative pain element will be lesser.
Thank you, sir. Thank you.
What percentage of your listhesis you do by minimally invasive, Ajay?
Not much. As I mentioned, is only 5% or less. It's only to keep myself challenging to do something different than what I have done. The most difficult aspect of doing a MIS is the fact that you have to unlearn what you have learned.
Right.
Your mindset to accept to do it in minimal access way. It takes time, but it's not difficult. It's only your adaptability to perform it.
So what is your ideal indication for a MIS patient?
My MIS indication would be number one, recurrent disc, because it's only on one side. Therefore, I don't have to worry about over-the-top decompression, number one. Number two, a light ecchystosis, wherein it's grade 1 or 2, but no significant radicular component, maybe on the side, because you don't have to decompress too much. When I think that I need to do a over-the-top, I am slightly, that I haven't done. It's just that I'm hesitant to do it, to try and go over the top to do it via the tube.
Thank you.
It's just that you have to adapt. It's not a difficult thing. See, putting percutaneous screws is like doing a biopsy. There's nothing difficult about it. The only thing about MIS is the fact that docking of the tube over the facet. It takes a learning curve because usually the muscle creeps in initially till you become more confident.
Thank you, sir.
Thank you. Thank you all.
Thank you, sir.
Bala has been able to.
So there is one more question in the chat box. Dr. Rajesh, sir?
Yeah, I'm listening to it. I'm going through it. In case of failed back operated previously by the midline, is it advisable to go for MIS? Definitely yes, depending on the indications. What do you mean by that? If you have to decompress completely both sides, then probably MIS may not be an ideal option. But if you think the problem is one-sided, if there is a recurrent disc or something where you don't have to worry about the midline aspect, then MIS is the option. Because when you have a revision surgery, putting a screw from midline is very difficult because the muscles are scarred. Whereas when you go through MIS, you can easily come from the outside in the direction in the parallel to the pedicle and put the screws. Bala, you are on.
Okay, JK shall start.
Yeah.
Welcome everybody to Trichy Orthopaedic Society. I'm just going to present a couple of cases. So, the first case is a 40-year-old housewife who presented with the intense right leg pain of few months duration. The straight leg raise test was positive at 45 degrees. There was no neurological deficit. This was her MRI scan. She didn't have any sign of infection. There was no suspicion of any infection in her history or examination. This is what Dr. Panikiran was talking about as the black disc. She had a L4-5 black disc with the axial view there, which didn't show much except a bit of lateral races stenosis on the right side, which wouldn't account for the intense right leg sciatic pain. What would you do next? Anybody?
Any stress X-ray, sir?
There was no stress X-ray as such. There was no instability. I didn't suspect any instability. There was no listhesis. So flexion extension views were not taken. She had quite intense sciatica. Anyway, the importance of CT, if you see in this MRI, you can see a lot of facetal arthrosis on both sides, more on the right side. So I did a CT scan, which showed a lot of arthrosis of the facet joint with the osteophyte pressing onto the foramen, encroaching onto the foramen. This was the cause for a pain. So this case is to emphasize the importance of CT scan when the MRI scan is fairly innocent. She did that. She had a mini open procedure for fenestration clavectomy and undercutting facetectomy, which relieved her sciatic pain completely. So if MRI is not contributing, do a CT with reconstructions. Sometimes diagnostic selective nerve root blocks can also be helpful in making an accurate diagnosis. So that was my first case, which is a very common scenario many people will face when patients present with severe sciatic pain and the MRI scan is normal. It's easier to get a CT and double check if there is any encroachment in the nerve root foramen. The second case is an interesting 45-year-old school teacher who had severe neurogenic claudication for more than a year, so much so that she was unable to go to work. She started developing unsteady gait for the previous 3 months and some hyposthesia in the feet, in both feet. Curiously, she had brisk knee jerks, but the upper limb jerks were also relatively brisk, had good pedal pulses. This was a lumbar spine MRI, which shows, among other things, quite tight stenosis at L4-5 level. These are the two parasagittal views. And she also has some ossification of PLL, OPLL, and the upper lumbar spine levels. But that was not causing much compression. What next? Jakesh? Mukesh?
How old is she, sir?
45.
45. She has got neurogenic claudication.
Yes. The watch was very limited.
Any CT was taken this case?
Sorry?
CT scan was taken?
CT was taken. Yeah, CT was eventually taken. But then her clinical symptoms and signs didn't fit in with just this L4-5.
Sir, do you have any whole spine MRI?
Yes.
look out for cervical myelopathy.
Yes. So this was an axial scan, which shows quite tight stenosis at L4-5, which will account for a neurogenic claudication and some paresthesia in the feet. But then the unsteadiness in the gait and some exaggerated reflexes were saying there's something else going on. And then this single sagittal profile MRI showed quite severe OLF compressing on the spinal cord, causing signal changes. There were a few more lesions above, but they were not causing much compression. This was the culprit. So the emphasis here is that when patients present with one significant diagnosis, if there are some clinical features not fitting in with that diagnosis, then we'll have to go a little bit more and look for other lesions. I find in some MRI centers, they don't do this single sagittal profile, which I think is very important for other pathologies above. We should emphasize on doing them when we request for an MRI. So
you must always order for a whole spine MRI.
Sorry?
You must always order along with the whole spine MRI.
Yes, one single sagittal section of the whole spine.
Yeah.
So the preoperative CT is mandatory in OLF. Unfortunately, I don't have the CT this is to assess the extent of OLF. It is most of it is parasagittal because the ligament of flavum gets ossified on either side because by its virtue of placement on either side is parasagittal. Even in the single midline sagittal screen, it can get missed. So if you have suspicion of OLF, you may have to get a whole CT. And another thing I found very useful was to mark the level, which at the time of surgery can be difficult in terms of radiation and a lot of hassle. But it's much easier to mark the level with the CT scan by the radiologist. She underwent meticulous excision of OLF, which is quite a demanding procedure, and decompression of the L4-5 in the same sitting, which relieved her symptoms and is back to her work and high level of activity. This was one of the intraoperative pictures which showed quite a good decompression of the thoracic spine at the OLF level. So clinical history and examination will give a clue to hidden pathologies. It's important to elicit them. Insist on getting a single sagittal spine profile in all cases. CT is very useful in delineating the bone mass prior to surgery and to mark the level. Thank you very much.
Thank you, sir. Thank you for a very good presentation.
Thank you, sir.
Stress on whole spine screening also. Whenever we are taking cervical spine or lumbar spine MRI, we have to stress on whole spine MRI to rule out any proximal or distal lesions.
Sure. What is the faculty's experience on dealing with OLF in general?
Ajay, sir?
Yeah, OLF is not uncommon in our scenario. People presume that OLF is uncommon in India. The ossification disorders, even OPLL and OLF, are relatively common. The only thing as mentioned is one of the common problems is missing. Number two, the second problem is missing the level. These two are the very important problems. Be very careful, use burr. I don't think it's a procedure should be done without use of burr. Using upcutters is not a ideal thing to use in OLF. Burr it, thin it, you can allow it to float or you can excise it, depending upon the ossification. Catch them early before they become inability to walk. With the gait disturbances, if you catch them, usually they tend to do well.
Yes, sir. Thank you, sir. We'll go to the next talk by Ram Chadha.
Jaykish sir, can you unmute yourself, sir? Jaykish sir?
Yes.
Yeah. Unmute someone. If you unmute it, only that audio will come.
Okay. Okay. Hello. Yeah, exactly. Yeah. The audio is okay.
Sir, audio little bit it's not clear.
Not clear. Okay, then we'll skip the talk.
So should I go ahead with my talk?
Yeah. Yes, sir.
Okay, right. So can I share my screen?
Sir, there is a green button. Yeah.
Can I share the screen? Yeah.
I can see that screen.
Yes, sir. You
Okay.
can sir.
Okay.
Jaykish sir, the video கொஞ்சம் நீங்க stop பண்ணிடுங்க. That audio is coming.
So I will just do the So at the outset, I would like to thank Dr. Jaykish and the organizers for giving me this opportunity. I'll be talking on degenerative spondylolisthesis. As we all know, it most commonly occurs at L4, L5 level, and it rarely exceeds more than 30% of slip. Usually, it is progressive only in around 1/3 of the cases, and around 40% of them improve with the first episode, and around 20% worsen and 40% remain unchanged. So this is important so that we can make decisions on the surgery by knowing the natural history. So surgical indications are quite clear. A progressive claudication which does not improve with conservative care, or an instability back pain which is distressing the patient, which is not improving with the conservative care. And we need to give a good amount of conservative care in all these patients, as more than 40% of them improve without surgery. So we need to give a good trial of conservative management. And there was a lot of debate on if the surgical decompression and stabilization is superior to non-surgically managed patients in a long-term period. This study by Weinstein, the sport study, has clearly shown that if the patient has degenerative spondylolisthesis with stenosis with a progressive claudication, the surgically treated patients, they did well more than the non-surgically treated patients. So is it so simple? Do we operate on all these patients who are not responding to conservative management? No, we have to be quite careful because many of these patients do have non-radicular pains and non-claudicating pains. They have fibromyalgia symptoms, non-organic or psychosomatic pains, which can be progressive by themselves and not related to our spondylolisthesis or stenosis. Another reason we have to be very careful is, patient starts expecting quite a bit of things once they agree for surgery. They want all the pains to be gone off because they have been holding not undergoing surgery, and now they are ready for surgery. It's up to you to take away all their problems. So we need to be very careful giving them realistic expectations there. We also have to be realistic about the back pain that only around 60 to 70% of them get good relief of back pain, and the best part is more than 90% get good relief of claudications and leg pain. So these things have to be explained to the patient, and their fibromyalgia or non-claudicating symptoms will be there. I just wanted to show you this case as Dr. Bala was telling also about the problems with clinical manifestation, which is not corresponding to the symptoms corresponding to the imaging that you see. Now, this patient actually was referred to me by an orthopedic colleague for surgery. So patient actually came prepared for the surgery, but somehow once I saw him clinically, he had that waddling gait, which was, tender groin and trochanterus, and the pain was even constant while he was supine. Not very much, correlating with the claudication pain you would expect in these situations. So because he had these groin pains and trochanter pains, I decided to take just an X-ray of his pelvis and hips, and we had looser zones there, and he was then diagnosed of hyperparathyroidism, and he is being treated for that. So we need to be aware of what the clinical manifestations are instead of just jumping onto surgery while we see the MRI pictures or the X-ray pictures. So the best situation would be, something like this, where the listhesis and the stenosis are matching the progressive claudication and the radicular pains. The patient is also understanding and has realistic expectations, which you can convey to them. And ideally, they should not be having non-organic pains, but usually these people do have a bit of them. So you need to explain that. The worst situation would be, like a mild listhesis here. As you see, there is no, instability, there is no stenosis, and patient complains of progressive pains, but there are no claudication pains, and distribution is non-dermatomal. They have comorbidities, diabetes. Some of these patients, they start insisting on surgery because they have done enough of other things, and they just want to get relief of all their symptoms by surgery. So you need to be careful in such situations when you advise surgery. Epidural steroids, especially the transforaminal ones, have been quite handy for us. We use them when the patients are going through our non-operative management. That also gives confidence for the patient that, if the pain recurs after the radicular pains and it is not responding, then we can assure them that these are things that are going to go off with decompression. So the radicular pains which they got relief, the claudication which they got relief a bit with root injections can be expected to go off with good decompression. Also, you need to be aware of the imaging clues. Again, here the dynamic X-rays are very, very helpful here. you need to also look around if there are gas signs, and a relative disc height gives you a idea about is the listhesis actually going for a autofusion. So here it might not be that much useful unless you find that it is only of radicular pains, nothing of an instability pain the patient has. So if the foramen is quite narrow, even in a centrally adequate space, that would be useful for a surgical procedure. Obviously, the surgical execution has been dealt with quite nicely by Dr. Ajay. I won't be going into that in detail, but yes, it's very important that you do a good decompression. We prefer a bilateral decompression, especially in these degenerative ones. And each of these patients, I mean, they are quite different. I mean, the way the roots are getting compressed, how you are going to decompress them, especially in the elderly with multi-level decompressions, that can be quite challenging. And I always keep telling my residents that we as surgeons are privileged. Like we need not depend only on the results of multicentric trials or long-term results of only papers, where the patient after the surgical decompression shows you how better you have done. So at each time, how much upcut you have put below the superior articular facet, how much compression of the nerve with the upcut it happened. So how much the symptoms of radicular pains will be there or it is exaggerated. So it's very, very dynamic for us as surgeons so that we can know how to modify our own techniques, our own indications in these patients where the compressions are quite different in each patient. Another thing that we nowadays come across is this multi-level listhesis, especially in the elderly, where most of them, say the patient like this who came to us, 68-year-old, who had progressive claudication since 3 to 4 years, and now came to us with a partial foot drop with inability to walk since 2 to 3 months. But she was advised that surgery will be quite complicated. We should not undergo surgery at this age, just manage it. Now, these things we need to address surgically. We know that without decompression, they are going to go down. So it's our duty to give them a chance as such. So yes, surgical decompression can be quite challenging, but as Ajay showed, like we do get into what is called as an en-bloc laminectomy. Here we just cut open the pars with the osteotome so that our decompression time comes down. I'll just show you a small clip of that. So instead of going along by the normal decompression with upcuts and ronges, we use these small upcuts, small osteotomes to cut open the pars there. So once the pars is cut, it is like a lytic listhesis for you. The whole of the operculum will be moving, and you can take it out in one go there. The advantage here is proximally the ligamentum flavum is there to protect you there, so we don't go completely there. You can see it here. The ligamentum is quite much there. You can see the amount of hypertrophy of the lamina there. So taking out piecemeal would be quite challenging. You can see the cord there. So then you can proceed on with your upcuts for the rest of the central decompression. Another important thing you need to realize in degenerative listhesis and degenerative stenosis is the amount of foraminal compressions. Now, here the superior articular facet is most often the culprit for the exiting nerve root. So it's important to realize that the facets are completely one over the other, and the superior articular facet is the one compressing the exiting nerve root. So decompressing the exiting nerve root is quite important. Here, I just want you to just have a visual impression of the superior articular facet here. We could not even pass the upcut there. You can see it is coming up till here. So once you take out the superior articular facet, there you can see the foramen completely decompressed. So once the foramen is completely decompressed, you can, in a minute, I will be showing you the exiting nerve root there. So you can see the whole of the superior articular facet was coming up till here there. So this is the nerve root below that, which was completely compressed. So you can see the lower edge of the root there. So it is going outside there. So unless we take out the superior articular facet in these foraminal compressions, the decompression would not be enough. And this also gives a wide area for our interbody work there. So this patient had multi-level decompression and fusion, and as we are a team, we could finish it in around 2 hours time with a less amount of blood loss. So this gives us the opportunity to get the patient up and about quite fast, and luckily she did not have any other complications, and her foot drop also improved, and she was able to walk around 2 to 3 kilometers by the end of 3 months. So we have our own experience of these elderly patients with multi-level lumbar fusions for listhesis and stenosis published in the Indian journal, Indian Orthopaedics journal. And we also have our share of complications. There's one of the patients, 72-year-old, for which listhesis fixation and decompression was done. Just 5 days post-op, she started complaining of severe buttock pain, unable to sit or even turn in the bed. So once we got an X-ray, you can clearly see here there is a fracture below the instrumentation, the sacral fracture. So this we need to be aware of. Once we recognize it, we need to immediately instrument it. Otherwise, they can't even sit and walk. It is quite painful. So once the fixation to the ilium was done, she was again up and about walking. So in conclusion, I would like to say that the indications for degenerative listhesis, it's a constant learning process. We need to be attentive on the clinical signs, and it has to correlate with the imaging. And it's better that we use most of the conservative methods and have an integrated approach. We do have our pain management specialists, especially, we have an in-house psychiatrist also. We counsel patients for realistic expectations, and yes, surgical execution and results, they constantly reshape our clinical decision making. And whenever you come across any complications, the most important thing is to recognize it promptly. And once you treat those complications, yes, they do get better. So I think I'll stop it here. Thanks for providing me this opportunity again. Thank you.
Thank you, Dr. Upendra.
Thank you.
Just one or two questions to start off. And do you, how do you explain a patient who presents to you at around 70 years or so with a grade 2 listhesis, who has not had any significant back pain or neurogenic claudication in the entire life? Have you come across patients? I'm sure you would have.
Yeah, absolutely. So they don't have symptoms, but they do have degenerative listhesis. That is what you are saying, sir.
Yes.
So once
not
they
degenerative, maybe lytic also, but grade 2 listhesis.
Yeah,
quite severe listhesis with compression, but then they have a very high level of activity.
So in spine, we always tell that, we explain that what is their situation image-wise, but if they are managing their own daily activities, we do give them the chance to go ahead and do their activities. It's especially important that we have a shared decision making. We can offer them the surgery once their daily activities are getting curtailed because of either the instability back pain or the claudication. And once they understand that this surgery is going to benefit that much, So it's important that we have a good counseling session with them. There is no straightforward answer for these things because each patient will be different. So they perceive differently the advice also. So we need to be careful, and it's always better that you put across the information and they take the decision.
Sure.
Excuse me, can I have a question? I'm Dr. Ravi. Can I have a question, please?
Yeah, surely.
So you said the surgeons have an advantage over the physicians in doing the. What did you really mean? What do you mean by that?
So basically, as physicians or medical people, you are almost entirely dependent on long-term studies. You are entirely dependent on the meta-analysis, the Cochrane analysis for your decision making. Whereas we as surgeons, yes, your decision making, everything you have learned and you have done the surgery. Now, once you have done the surgery and you see your post-ops, your patients, how they are doing, I think that learning is something that is first-hand for you. Rest, everything is second-hand. So that is where a surgeon is, privileged over the physicians, where the time for their interventions take a longer time, and there will be a lot of biases in between why the patient improved. For us, the surgery is such a drastic, sudden, and one-time intervention. We know how much it is helping. That is something that is very, privileges for a surgeon, I feel.
Is there any? Are you sure that epidural steroids for these situations are they really FDA approved, or we are doing it without any FDA approval?
No, they are used all over the world. The only
all
controversy happens
over the world. But is there any FDA approval for that using steroids epidural?
FDA approval is not required in India. Absolutely not required. So we should not be in that frame of mind.
When I say FDA, it is the DCGA approval.
So in India, absolutely no problem. You are within the limits of the law to offer epidural steroid injections. So it's upon your clinical decision making that, if you want to offer them. So it's absolutely scientific to offer a transforaminal or epidural steroid injections. There are, large pain management institutes in India where they are offering it. So absolutely no problems. You can offer it.
Thank you. Thank you.
I saw Ajay's comment that only Depomedrol cannot be used. Why not? Can you elaborate on that, Ajay, please?
Depomedrol is a particulate one where there was actually, we all know it, there was a litigation where they objected the use of Depomedrol epidurally because the manufacturers had written that it can cause a bit of arachnoiditis. Now, one of the issues, arachnoiditis.
All right. Okay.
So that's a glitch because if you are using it in the epidural space and the patient has an arachnoiditis, it becomes difficult for you to defend. So you can use a non-particulate one. You can use something like Dexona, so which is absolutely fine. And Dexona, they do use in cervical also. So absolutely no problem in using a Dexona. So we do use that.
Do you use PRP for that?
No, we don't use PRP. No, we have no experience in using PRP.
Triamcinolone alone is available, tripod. Can we use tripod? Is that okay? Is it particulate?
I think tricot is also a bit particulate matter compared to Dexona. So epidurally, probably it is better than Depomedrol because there is no contraindication that is written in its use. But once we have such a litigation, we prefer to use the Dexona.
Upendra, how many percentage of cases you do decompression alone without instrumentation in degenerative spondylolisthesis?
So basically, we start seeing how much is the central stenosis as well as instability that is there. So if we feel that a significant back pain and instability is there along with the central stenosis, we prefer to do a complete facetectomy as well as central decompression along with instrumented fusions. We do decompressions only when there is a stable spine, minimal instability related back pain, and only a radicular pain, especially on one side. So we do decompressions there. So those are the ideal indications.
Mukesh?
Yes. Upendra? Yeah.
Thanks. Yeah.
That was a wonderful talk. I have a doubt. Like in a multi-level degenerative diseases, in what percentage of patients you use neuromonitoring, or do you use it or you do not use it?
Yeah, I mean, neuromonitoring, it's useful as a concept if you can reverse something that you are doing. That is the basic concept of neuromonitoring. So say you are doing a high-grade spondylolisthesis and you are trying to reduce it. There, probably monitoring the L5 nerve root might be quite beneficial because it will allow you to grade how much of reduction is causing stretch. Whereas in these degenerative ones where you are directly decompressing the nerve root and you are not doing any deformity correction or pulling and pushing there, your injury will be most often because of direct forces. So it is either with upcut, it's either with whatever maneuvers you are doing for decompression. So there is no scope of reversing it. So there is no use of neuromonitoring. Even if you know that you have damaged it, you can see it is damaged. You can't do anything.
Okay, right. Thank you.
Yeah.
And regarding this particulate steroid, see, have you used this Depot-Pred, which is available from one of the Sun divisions?
Okay.
If you see those manufacturing it doesn't show any preservative, and if you see the solution also, it is a uniformly formed one. It is not like a particulate thing like a Depot-Medrol.
Yeah, one of my pain management specialist also uses that. Yeah, probably we have not put thought into it because it's working fine with Dexona for us. So maybe we can use it. Should not be an issue. Yeah.
Thank you. Thanks for joining.
Thanks. Thank you.
So with that, shall we close the session?
Yes, sir. Dr. Rajamani is held up with some other meeting in Dindukal. So we can close the session, sir.
Okay, fine. So I would like to thank the faculty for joining us in the Trichy Ortho Society meeting on this World Spine Day webinar, which has been quite useful. First and foremost, I would like to thank Dr. D. Shivshankar, the IOA President, and Anthony Vimalraj, the TNOA President, for joining us, and the faculty, Dr. Fanikaran, Ram Chadha, Dr. Ajay Shetty, Dr. Upendra, for their enlightening talks on this day. I would also like to thank Jaykish and Mukesh for taking pains to arrange this webinar in spite of some of the audiovisual difficulties. I hope the message from this World Spine Day can be distributed to the wider public by making them aware of various degenerative conditions by all the members who have candidates who have attended this webinar. And last but not the least, I would like to thank Alembic for arranging this webinar and helping us to learn a few important things today. Thank you very much, everybody.
Bala,
Thank you,
sir. Bala, can you hear me?
Yes, sir. Please go ahead.
So, yeah, one thing which I wanted to say was this role of steroids in orthopedics. So we have been using steroids left, right, and center for every indication, whether it is tendon, ligament, wherever joint. So we were using steroids only as a stopgap arrangement. Steroids only temporarily relieve the pain, temporarily reduce the inflammation. Whereas wherever we have injected, they have produced more degeneration. So in a long term, steroids always do more harm. So now the trend is shifting towards using of anti-inflammatory effect plus regenerative effect instead of anti-inflammatory effect plus degenerative effect. So more and more orthopedic surgeons are already using platelet-rich plasma wherever we have been using steroids. So steroid, whether with though there are multiple preparations, all of them have the side effects and other late effects. So I'm seeing a lot of orthopedic surgeons taking up this PRP and the other regenerative procedures. So is it really is it really doctors are using more of that?
Probably in joints, I think it makes quite a good sense, I think, but I don't know the results of it. In spine, I don't see that we can regenerate the facet arthritis, or we are using it mostly in.
See, arthritis, it is the same damage. What is the cartilage damage as well as the osteophytes which are formed.
Right.
There is a reduction in all those things when we use either PRP or stem cells in large joints. So I think we need to do more studies.
Probably, yes. We have to have more evidence for that. We should be open for that. So if it can reverse the facet arthritis, yeah, wonderful it would be.
Yeah. Thank you.
Thank you, sir.
Thank you, Jagesh. Thank you.
Thank you, Dr. Balasubramanian, for moderating the session. And
thank you, sir. Thank you.
You finished in time.
So we have a tomorrow session. Yeah. So tomorrow we have a session. No, sir, again.
Yes, sir. Tomorrow we have promo session.
Yeah, yes.
Okay.
We start by 7 o'clock.
Day after tomorrow, we have this arthroplasty session,
Sure.
which starts around 7:30. Okay.
Yes, sir. Yeah. Okay. Okay. Fine.
Thank you. Thank you.
Thank you.
Thank you, sir. Thank you. Thank you. Yeah, Mr. Rahul Jagan. Rahul, are you in the line?